Hello, everyone. This is Chadi Alraies coming to you from RSH 2026. I'm really privileged to be Dr. Ali Vazir to talk about, from heart failure perspective, which is really new, how to tune up these patients with tricuspid valve regurgitation before they undergo procedure, and also how to manage them after. Ali, thanks for being with us.
Thank you. Thanks, Chadi, for the invitation.
It's a challenging population, and we start to know about them more. So tell us about how, from heart failure.
So from our approach that we have at Royal Brompton Hospital, we essentially try and understand the pathophysiology or the phenotype of the patients. So we gather the information from transthoracic echo, transesophageal echo, and also right heart catheterization. So we phenotype the patients. For example, do they have ventricular secondary tricuspid valve regurgitation, or do they have atrial functional or atrial secondary tricuspid valve regurgitation, or do they have primary disease, or is it secondary to pulmonary hypertension? So using these investigation techniques, we can phenotype the patients and then home in on what can be reversed with medical therapy. So for example, if the patient has left-sided heart failure with reduced ejection fraction, the patient should be on 4 pillars of heart failure therapy. If they have mildly reduced ejection fraction or preserved ejection fraction, they should at least be on SGLT2 inhibitors or MRA like finerenone or spironolactone or eplerenone. And other drug therapies like ARNIs or angiotensin receptor blockers could also be considered for this phenotype of patients. For the patients who have long-standing atrial fibrillation, who develop atrial dilatation, and the right heart catheterization shows no evidence of raised pulmonary pressures or raised left-sided pressures. So in those patients, we're more focused on treating their volume status. Right. And again, we would consider SGLT2 inhibitors and MRA in this population. We find that patients who have ascites probably benefit more from higher doses of MRAs like spironolactone or eplerenone. Just to keep that at bay. Treating the volume status is also sometimes challenging in these patients. They have chronic renal dysfunction and some liver dysfunction, which makes it challenging. So often we have to use higher doses of diuretics. So for example, if the patient has lack of response to standard doses of diuretics, we would use higher doses of loop diuretics, combine diuretics together to try and achieve the decongestion, because that's one of the things that we find makes a big difference, the volume of the right ventricle, the degree of tricuspid valve regurgitation. And often you find that after the adjustments in medical therapy, after the reassessment of the patients, we find that the patient's severity of their tricuspid valve regurgitation may improve. And sometimes these patients, all they need is good medical therapy. Yeah. But often when we find, despite medical therapy, they have moderate severe tricuspid valve regurgitation or torrential, then definitely a procedure is required. But the optimization will help with regards to the procedure, because sometimes we find when the gap size is too large, decongesting the patients very well, bringing them in a few days beforehand, giving them IV diuretics at high doses or combination of diuretics can often reduce the gap size and make a patient who's ineligible for tricuspid tier more eligible for tricuspid tier.
Speaking of optimization, as you mentioned, bring them a few days before the procedure, is there a role for like inotropic therapy to augment diuresis like milrinone, epinephrine, just to help the RV?
So I think, again, that comes down to the phenotype of the patient. Yeah. So I think the right heart catheterization data and the echocardiogram data would be very important. The response to the diuretics are very important, because if you can achieve diuretic response with medium doses of diuretics, sometimes you can get away with not using inotropes or vasopressors. Often these patients have lowish blood pressure, and using vasopressors or drugs like renal dose dopamine can sometimes make them more responsive to the diuresis.
Post-management. Now, the patient is, let's say, finished, and they go back to you, right? Because you are the referring physician and you are managing physician. Is there? How do you see the RV behave post this intervention, whether clipping or replacement?
Yeah, very good question. So I think a lot of the patients that we treat, we find that they require maintenance of the doses of diuretics. And I think the way we look at their RV is obviously through imaging, but also how they respond clinically, whether they're responding to the medical therapy, whether there's been a change in their renal function. Do we really see an improvement in their cardiac output clinically? And I think this is the way we would tend to treat the patients based on how they've coped with the procedure. So if we find that in the majority of cases, we continue with high doses of diuretics until we see confirmation that the patients become a bit more sensitive to diuretics. We're seeing the side effects of diuretics. At that point, we start reducing them, as opposed to reducing them early on, thinking that we've made a good achievement and it's now time to reduce the diuretics, irrespective of the clinical response and the imaging response. So I think we just look at what happens to the patients clinically in terms of their biochemical profile, the side effects of diuretics, and also their hemodynamics.
From your experience, have you noticed these patients, especially who have recurrent ascites that require paracentesis, they get away with that anymore? Like they completely resolve to the level like they don't need to have it done?
So that's a very good question. So often these patients, so we use the tri-score to try and risk stratify our patients. And often the patients who have established cirrhosis, it's very difficult to sometimes reduce the risk of need for future ascitic drainage. We find that I think the procedure itself can make a difference in terms of the frequency. But again, I think how effective the treatment has been is probably more important. Often we find that these patients with ascites have a very large right ventricles as well, because they're quite advanced in their condition. And those are the patients ideally who would probably need replacement of their tricuspid valve, but they may be too advanced in terms of their RV to be able to cope with that sort of sudden improvement in their tricuspid valve regurgitation. So we end up sometimes, if they're eligible for TEER, performing TEER, but we don't necessarily get the optimal results. So we're left, for example, with moderate tricuspid valve regurgitation. Those are the patients which I find are stuck, and they may not respond so well for the hemodynamic benefits of the procedure, and they still are dependent on medical therapy and occasionally ascitic drainage.
Very, very great insight about pre and post management of tricuspid from heart failure perspective. Thank you, Dr. Ali, for your input. Watch the videos and others on the YouTube channel. This is Chadi Alraies coming to you from RSH 2026. Thank you so much.
Thank you. Thanks.